Hello everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and on tonight's program, we will be discussing the field of urology. We are live with you here at our studios at ACTN. Tonight, back in studio with me tonight, is Dr. Trudy Kawal. Dr. Kawal is a specialist urologist at the San Fernando General Hospital. Dr. Kawal also has offices at the Southern Medical Clinic in San Fernando. As usual tonight, our number should come up at the bottom of your screens, and we will do our very best to answer each and every one of your questions during the program. So guys, let's talk urology. Let's discuss all your different complaints in urology, and let's say welcome back to Dr. Trudy Kawal. Trudy, welcome back to the program. Welcome back to Your Health, Your Choice. How are you?
I'm fine, thank you. Thank you for having me back on your show.
You're very welcome, Trudy. You're very, very welcome. So, Trudy, you were last here in January, all right?
Yes.
So roughly 9 months ago. In the interval since then, has there been much developments in the field of urology, much technologies that have been introduced for diagnostics or therapeutics? Has there been much studies or research going on in Trinidad and Tobago in the field of urology? Just to start off.
Definitely. Urology is a field that's we're always on the go, and we're always trying to maintain our standards with the international standards.
Right.
So, as we spoke about last time, there are many different technologies we use in urology, the most common ones or the most high-tech ones being different forms of lasers.
Right.
However, we've been doing a lot of research into how different conditions affect urology. So one of the latest projects that I've recently worked on is looking at the impact of diabetes on urology, because a lot of people think that diabetes is just a medical condition and it has to do with the blood glucose or the blood sugar, but they don't realize that diabetes, being an endocrine disorder, has far-reaching effects throughout the body.
Right.
So, for instance, diabetes may cause things like erectile dysfunction. It may cause recurrent urinary tract infections in both men and women. And there is a complex called the diabetic cystopathy. And what that means is diabetes itself affects the bladder and bladder function.
Okay, Trudy, if I could slow you down there a little bit. So, so those are the complexities that diabetes causes in urology, so to speak, the complications in your field. So, what is it that you're studying? I mean, how are you going about this study?
So what we are doing is we identified a cohort of diabetic patients.
And this is throughout Trinidad and Tobago, or?
Mostly based within South.
In the San Fernando General Hospital?
Yes, that's where we've been starting off.
Right.
And then we can expand it to try to involve other regions.
Right.
And we're going to look at a cohort of diabetic patients, and what we want to see is if they have any of these urologic complaints.
Right.
And what we're also doing is I'm examining my patients who come in for urologic problems to see how many of them actually have diabetes and if their diabetes is well controlled or not.
All right. So I think we kind of know that diabetes causes these symptoms, right? So what is the end purpose of the study? What do we hope to do from the study? What is the benefit to the public?
So one, the benefit of the public is to educate and raise awareness that these things can happen. But two, we want to look at diabetic control, and we're hoping to find in our study that improved diabetic control results in fewer of these urinary complaints.
All right. All right, so I suppose you're trying to get a percentage of people who might be affected with the condition who have diabetes.
Definitely, and to show, and we're hoping that when we do the analysis, that it will show that those who are well controlled have a lower chance of developing recurrent urinary tract infections, things like that.
All right, so I suppose you're trying to put quantitative analysis to a theory or to a condition that we see commonly in clinical practice.
Yes.
All right, so that's an interesting study. What else is happening? What else are we doing in medicine, in urology in Trinidad? What other studies yourself or others might be involved in at the moment that you'll be willing to share with the public?
Well, on a continuous basis, one of the things that we've been looking at within our clinic system is the number of surgical cancellations for urology. And I've noticed internationally there's a published scoring system to determine the importance or how to stratify or prioritize the waiting list. And so I've been looking at the different criteria that they use to see if this is applicable in our population.
All right. So what I'm getting back from you is I'm probably trying to apply international best practice guideline that has been developed recently.
Yes.
And apply it to us here in Trinidad.
Yes.
And see how best we could structure our waiting times with international standards.
Yes. So it's just in order to basically make a proposal or a hypothesis to see if this is something that we can implement in our setting.
And therefore increase efficiency in the urology waiting list. Any other studies out there that you all are doing?
So we continuously try to every year develop different projects.
Yeah.
Some of the ones that I've worked on is looking at the side effects of different treatments that we've used for prostate cancer in the past.
Right.
And this is just to see, because when patients come to us in clinic, they ask for data. They ask, so
of course,
how likely am I to have this side effect? How likely is this treatment to work? And we have international data.
Yes.
And what we've been trying to do is come up with a wealth of local data as well.
Of course. The one thing I kind of noticed from having done this show for more or less 1 year, and even my predecessors, well, we kind of noticed that we bring on sometimes guests for different specialists in different fields, and there always seems to be a paucity of local data in the medical conditions and local statistics. So it's good to see that that you're trying to get those statistics and trying to get that data in the field of urology, and urologists here in Trinidad are doing that.
Yes.
Because we need our own data here in Trinidad to know about our own population and to postulate and to treat our people in the future as well.
Definitely.
All right? So Trudy, I just want to move you a little bit away from that. I mean, we educated the population a little bit about what's happening in the field, let them know that we're doing things here locally. But very importantly, right, in general practice, sometimes you get these phone calls in our office, or sometimes the patients come in and we get, doctor, I'm really concerned. I've noticed that I have some blood in my urine, and sometimes patients may take it on and come and see the doctor. Sometimes they may ignore it, or sometimes you might pick it up in the clinic setting. So blood in the urine is a kind of real common complaint that we might hear about. Could you just take us a little bit through that? What should we be alarmed? What should the patients be doing? Could you just discuss that topic?
Definitely. So blood in the urine always warrants some
it's called hematuria in medical
term. The medical term is called hematuria, and it always warrants investigation. Now, there are two types. As you mentioned, the patient may call and be alarmed and say, Doc, I'm seeing blood in my urine.
Yes.
Another common presentation is when patients come to their general practitioner and they have a urine dipstick test and it picks up a trace of blood.
Right, that's quite common as well.
And that's called microscopic hematuria.
Right.
So what I try to explain to patients is blood that you can see, that's gross hematuria or blood in the urine.
Yes.
Now, both of them warrant investigation.
All right.
If there is persistent trace of blood on the dipstick analysis by a general practitioner, the next test that needs to be done is a urine microscopy, culture, and sensitivity. What that is when you pass the same urine sample, it's looked at under the microscope by a pathologist, and we determine the number of red blood cells.
Right.
More than 3 red blood cells warrants further investigation with imaging such as an ultrasound or a CT scan.
Right.
And sometimes with a camera test called a cystoscopy, which is something that would allow us to visualize the inner lining of the bladder and the urinary tract. Now, if you see blood in your urine, meaning that you're passing urine and it's red, then you definitely need to see a urologist. The line of investigation would go similarly with the urine test, some sort of imaging to evaluate the entire urinary tract, and that would be from the kidneys all the way down the urinary tract to the opening of the urine passage in both men and women.
Right.
And so the thing about blood in the urine, sometimes your urine may just be discolored. It may not actually be blood. It may be slightly brown.
Right.
But you won't know until we do the actual urine test.
Right.
Additionally, if you notice you've been passing clots, we'd ask you also if there's pain or if there's no pain on passing urine.
Right.
Basically, once you have blood in the urine, the site of bleeding can be anywhere in the urinary tract, and that is in the kidneys, the ureters, which are the tubes that drain urine into the bladder, as well as the urethra or urine passage in both men and women. In men, the prostate can also result in bleeding. It can also be a source of bleeding, and that is why, depending on the patient's history, investigations must usually be done.
Okay.
One of the things I want to highlight is that specifically with blood in the urine, in people who are smokers, one of the things that we need to rule out is any sort of mass or abnormality.
Right.
And this is why we tend to be more assertive with investigating these patients.
Right. So it's certainly something not to be ignored.
Definitely.
So you kind of highlighted the different kind of investigations that you have to do, and then you kind of related that maybe smokers might be at risk of mass or cancers or in the urinary system, which is your specialty. What other causes or common causes of blood in the urine, like the gross blood in the urine that the patient that might cause that for the patients?
So simple things first, a urinary tract infection, inflammation or any severe infection of the bladder can cause it.
Right.
The most worrisome cause is a tumor somewhere in the urinary tract, and that's why we have to check for it.
Yeah.
And as I said, in men with prostatic enlargement or prostate cancer, sometimes they can also have blood in the urine.
And I mean, this is probably regardless of the age group of the person as well.
Yes.
Because sometimes you might have young guys might have blood in the urine. It might go away. Might come back, but they say, look, I'm feeling good, I feel fine, I feel normal, and I'm young, and they might ignore it. But what you're saying is that no, don't ignore it. It needs to be investigated.
Definitely, because if there is an abnormality, the earlier it's picked up, the easier it is to treat.
Okay. And a lot of times it could be a not serious abnormality as well. Right?
Yes, that's true. A lot of the times it may not be that.
Yeah.
You may have a small stone which is being passed, and because of the bruising of the urinary tract, you see a little bit of blood-stained urine.
Right.
In some patients who are on aspirin or patients with heart disease who take what we call blood thinners or anticoagulants,
could be related to that.
Every now and then they may get a little bit of blood in the urine.
Right.
It's not something to be ignored. It's definitely something we should still investigate.
Okay. So you were saying there was the one that picked up on the dipstick, which is the microscopic hematuria and the gross hematuria. So I suppose the investigations and the causes and the possible causes are both the same in both conditions?
Yes, they are both similar, but just patients tend to present in different ways.
All right. I just want to backtrack a little bit, right? I think it might be remiss of me to have ignored. You said that when you were doing your recently, in terms of the recent technologies that have been applied to Trinidad, you said you talk about lasers. And maybe I was a little bit remiss because I cut you short. Could you explain that over again? What kind of new lasers are there, and what are lasers, and what are the lasers used for in urology? So laser
is an acronym. It actually stands for Light Amplification System Emitting Radiation.
Right.
And what a laser is a form of energy.
Right.
So it's just a more efficient energy source that we can use to target different organs in the urinary tract.
Right.
So the most common laser that we use is the holmium laser.
Right.
And there's also another type of laser called the green light laser.
Right.
Now, these lasers, we use them most commonly for stone disease.
Yeah.
So in patients with kidney stones, bladder stones, or ureteric stones, what we do is we use this laser energy through cameras to target the stone, and we basically pulverize it. And that's called either dusting or fragmentation, so that you never have to have a cut on the outside.
Right.
And so the laser is an energy source that we use basically to break up the stone.
Right.
And that's called laser lithotripsy.
Right. So is it that there is now technology available for better quality lasers?
Yes. So within the last 2 to 3 years, we have had that laser installed in Trinidad.
Right, so improved version.
Yes, basically. So it's basically a more improved version, a more energy efficient version. And this particular laser, it has something called Moses technology, and I'm really fond of that term. The reason it's called Moses is because if you're familiar with the biblical story where Moses part the sea, the Red Sea, basically the laser fiber fires 2 successive pulses at once.
Right.
So the first pulse basically carves a pathway for the immediately fired second pulse, so that it hits the stone with more efficiency to break it up in a faster manner.
I understand what you're saying. It sounds logical there.
Yes. So it's really, we say it's new technology, but it's based on a 2,000-year-old concept.
True. So, the laser is used for the for stones, renal stones,
Yes.
kidney stones. Is there any other application in urology?
Yes. So the holmium laser, as well as the other type of laser, which is the green light laser, they're both used for prostate enlargement.
Yeah.
So in patients with very large prostates with benign prostatic hyperplasia,
Yes.
they can have what is called an enucleation or a laser surgery,
Yeah.
or vaporization of the prostatic tissue.
Yeah.
And therefore it's the tissue is ablated.
Right.
So it is a form of surgery
Yeah.
for prostate enlargement as well.
Right. But we've been doing this before in Trinidad for
Within the last few years, it has come on board.
how many years? So roughly.
Maybe 2 to 3 years.
All right. Previous to that, we were just doing the surgery where we were doing what? Removing
Previously,
shavings of the
we do
prostate
the
and removal of the prostate.
shaving of the prostate, which is
Right.
called a TURP, or transurethral resection of the prostate.
Yes.
Which is still a good operation.
Yes.
And we do open prostatectomies, which would be to remove the prostate in a similar manner, but this would be open surgery.
Right. So now with the laser, what's the
Now
advantage?
with the advent of laser, so it's scarless surgery. There's no
Right.
cutting,
Right.
so there's a much shorter recovery time.
Okay. Okay. And the results are just as good as the traditional form?
Well, we have to basically audit all of these results in the long term,
Right.
but I believe that short term, there's been good results.
All right. And internationally, we've been using this laser for a long time?
Yes, and there are many published articles to say that it is effective and it is safe.
Okay. Okay. So that's for people with enlarged prostates, right?
Yes.
And
It is
is that for people with prostate cancer as well?
No, it's not a form of treatment for prostate cancer.
All right. Has there been any new technologies or techniques for treatment of patients in Trinidad with prostate cancer?
Well, treatment of prostate cancer is definitely multifactorial, and it depends on many different factors.
In terms of surgery?
In terms of surgery, there hasn't been anything particularly new. There's a standard treatments depending on the risk. There's radical prostatectomy, which is surgery to remove the entire prostate.
Right.
And that is a separate operation from the enlarged prostate surgery.
Okay. Let me just ask you, like a few weeks back, we had a general surgeon on board. I mean, I'll call his name Dr. Singh, and he was talking about some of the recent advances in general surgery, and he was telling us about the robot. And the robot this robot was helping them to get better fields, better vision, better control,
Yes.
and more precise surgery. And I thought it was just wonderful improvement in surgery.
Yes.
Is there any any sort of application in prostate surgery, or do you all use that in prostate surgery here in Trinidad yet? Or?
We currently don't use it.
Right.
Many
Is it being
years
used
ago,
abroad, or?
Yes. So many years ago, we did have a demo in the urology theater from
Right.
a visiting surgeon from the UK,
Right.
who brought with him a robotic arm to demonstrate.
Is it the same machine that would use for general surgery?
I am not 100%
Okay.
sure, but
Okay,
I
that's fine.
believe it is a similar concept.
Right. Right.
However, that was just it was something that was just shown to us. It was a demo.
All right.
We don't have that technology internationally. However,
Yeah.
robotic prostatectomies are done worldwide.
Okay.
But you must have the actual Da Vinci robot.
Okay. All right. Trudy, now is a good time for us to take a little break. When we come back, we'll just push on a little bit more about the different conditions. I was just picking your brain to the benefit of the audience in terms of latest technologies
Sure.
and research. All right, guys. So we're here with Dr. Trudy Kawal. She is a specialist urologist based at the San Fernando General Hospital and Southern Medical Center in San Fernando. I would just like to formally invite you to send in your questions and comments to us. The numbers are at the bottom of the screen, and we will certainly address it. All right, guys. So we'll be back in one moment. Thanks a lot.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. There's nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. So, Trudy, before we broke off into the break there, we were talking about different technologies. I want to ask you something directly into actual urology itself, something that really affects the general practice population, urinary tract infections. Why is it that sometimes some patients tend to get repeat urinary tract infections, especially women, I might think. How could we approach that? What might be causing that? And secondarily, as well, just today, a patient brought her mom in to see me, and I told the patient that, look, your mom who's in her 80s, that, look, she has a urinary tract infection. And she's like, Robin, why does mom keep getting these urinary tract infections? Can you just address that issue there for me, please? Because it's a very common complaint in the society. Urinary tract infections.
Yes.
So why would people get repeat infections, and why are the older population more susceptible?
Definitely. The older population is definitely more susceptible to forming urinary tract infections, simply because sometimes they don't have the mobility to go and speed to go to the bathroom as often as they need to.
Right.
Now, typically, women are much more prone to having urinary tract infections than men, and this is due to the anatomy, where the female urethra or urine passage, where we empty urine from, is much shorter than that of the male. It's about 4 centimeters, whereas in the male, the urine passage is actually around 20 to 25 centimeters. And because of the anatomy of the female, with the close proximity of the anal region as to the urethra. And so therefore there's much more risk of bacteria entering the female urinary tract.
Right. So that's why women get it more commonly.
That's definitely why women get UTIs much more commonly.
And why the elderly will get it as well.
And additionally, now men may get urinary tract infections as well. However, in both sexes, what we need to identify, rather than just treating the UTI, is why the patient is getting a UTI in the first place.
Okay, go on.
So we'll say that in men, usually it's due to some reason where they are not passing urine effectively.
Right.
And this is well known in men with prostate disease, which I think we've been talking about before, and this is something that's well explored.
Yeah.
In women, however, what I found very often, women who have recurrent urinary tract infections, once the infection is discovered, meaning that they pass the urine sample and the test conclusively shows there's bacteria in the urine, definitely we will treat with the antibiotic that works against that bacteria. But generally we need to prevent this. So how do we do that? By promoting good bladder health. And what does that mean? First of all, it's simple things, simple measures, like ensuring good personal hygiene, which most women do anyway, keeping well hydrated, and not holding urine. Many women, especially working women, who are at jobs where they feel that they can't take proper bathroom breaks, they tend to hold urine or retain urine.
And that would lead to increased risk of urinary tract infection?
Definitely. Once you have stasis, which means the urine remains in the bladder without being emptied at the appropriate time, there is a risk of urinary tract infection.
Just a real quick question. How often a day does someone have to use the bathroom to pass urine? Is there like a set, should we empty our bladder routinely every 2 hours, or how does it go?
There's no set time.
Right.
The reason being, how you empty or how you void, it depends on your hydration status,
right,
which is impacted by the amount of fluids that you drink,
right,
and it's also impacted by the temperature of the room.
right. Okay.
So I can't give you a number of times that a person should void. But very often women who work at jobs where they feel that they must hold their urine, they know they want to go, but they can't afford the time to do a bathroom break.
The most likely scenario that hits me is really like women who are stuck in traffic.
Yes.
Because I mean, it's really standstill traffic.
Definitely, and well, it's known in cashiers as well.
Standing all the time.
Standing and not being able to leave the register until their appointed bathroom break.
So that's something that people need to bear in mind.
Definitely. So additionally, aside from voiding when you need to go, the other thing to promote good bladder health is actually cranberry supplements.
Okay.
And this is something that's it's not herbal, but it's not it's not medicine. Right. And what they found in isolating a compound within cranberries, so it's a long name, it's called proanthocyanidin, but for short PAC or PAX.
Right.
And studies have shown that this complex actually is effective in promoting good bladder health and preventing UTIs.
Okay.
The problem is, no one knows, or it hasn't been discovered exactly how much of this you must have every day in order to prevent a UTI.
Okay.
So what I advise my patient with recurrent UTIs to do is just in the interest of good bladder health, have some intake of cranberry per day. And that could be cran water, cran juice, cran gummies, if you use cranberries in your diet. My only caution is if you're going to use cranberry juice, just look at the sugar content as well.
All right. That question about the diet leads me to an obvious question that we ask commonly. Does diet play a role in urinary health? Is that associated with urinary tract infections or prostate infections? Is there something that we should be, is a poor health or poor diet related to that? And is there something that is useful in our diet that might help us prevent those infections other than cranberry?
So in terms of usefulness, the main thing to prevent urinary tract infections is to keep well hydrated. Okay. Plus or minus the use of the cranberry supplements just to promote good bladder health. All right. In general, the diet recommended to maintain good urologic health is the DASH diet, or dietary advice for stopping hypertension. Okay. And that is basically a diet that says eat less processed foods, more fruits and vegetables, have a more balanced diet.
Okay. Okay. I suppose I might just want to bring this to your attention. I don't know what your comment on it is, but urinary tract infections, people tend to get them often. Sometimes people get them often, and you discuss a whole range, a whole gauntlet there. And then we're also hearing from the rest of the world, be careful about the use of antibiotics routinely and the overuse of antibiotics. Yes. And my humble observation, I think probably from the population out there, we tend to probably too easily use antibiotics without seeing a doctor sometimes in Trinidad. I don't know if you agree with what I'm saying or not. And sometimes the overuse of antibiotics without clinical testing or clinical data could sometimes cause antibiotic resistance. And sometimes people get infections that might not respond appropriately to the antibiotics the doctor get because they might be antibiotic resistant. What do you think about what I said there?
Definitely, you've definitely said a whole lot there that just hit the nail on the head for me. Yeah. So basically, my next point was going to be, I have seen recently a lot of women who complain of urinary tract type symptoms, but their urine tests actually showed no infection. Yeah. And so urinary tract infection symptoms would be frequency of urine when you feel like you have to go all the time within 5 to 10 minutes of the last time. We see a lot of those as well recently. Urgency when you feel like you can't hold urine. Yeah. Having to wake up a lot at night, having to force or wait for the urine to come out. Yeah. Or sometimes feeling the urge to void, but just very little urine is coming out. Yeah. And in some of those women, they also complain of discomfort, burning, pain, lower abdominal pain. Yeah. Now, the first thing we do is rule out a urinary tract infection. Yes. But very often, patients have no actual bacteria, no active infection, but they complain of these types of symptoms. Yes. And there are other types of urinary health problems that can happen that's not a UTI. Right. So in some women, they may have overactive bladder. Yeah. in some women, they might have interstitial cystitis.
Yeah.
And the hallmark of the interstitial cystitis, which is basically a generalized inflammation of the inner lining of the bladder, is this abdominal discomfort or pain, what they describe as a pain on the inside, on passing urine, and continuously feeling that they want to pass urine. And so a detailed history is really necessary to clinch the diagnosis, because the treatment, the spectrum of treatment is actually different. So giving these women empiric antibiotics, meaning that we just give you a course of antibiotics because you have urinary tract infection symptoms, may not actually solve anything. And they continue to feel these symptoms.
So basically what you're saying is sometimes a urinary tract infection might be misdiagnosed.
Definitely.
Because they have some of the symptoms of a urinary tract infection without an actual bacterial component.
Yes.
All right, so I mean, we put it out there for the population to hear. I'm very much aware that people who suffer from this condition would understand the exact work language that we're using, you know what I mean, the medical language. They would understand the jargon because they suffer from it.
Definitely.
All right, so just another little highlight or warning to the population to be very careful using antibiotics without prescription. It's not something that you go and take routinely without seeing a doctor or being prescribed, because there's a whole syndrome of antibiotic resistance that we're seeing, and it's making medicine very hard. And we could only discover newer classes of antibiotics so fast.
Yes, definitely.
And we're giving the microbiologists real hard work as well.
Yes, because when antibiotics are prescribed routinely, after you take a certain number of courses, your body actually becomes resistant to that antibiotic. So if you do get an infection, that particular antibiotic may not work for that infection.
And we've seen it all over the world right now in hospitals especially as well. So that's the patient. So why in particular would the elderly people sometimes get it? Is it only because they can't mobilize to the washroom quickly enough? Or is there any other particular reasons that an elderly person will get a urinary tract infection? And I've noticed that a lot of times, sorry to be prolonged in the question, that a lot of the elderly women sometimes have no overt symptoms of urinary tract infection. They don't really complain of burning when they're passing urine. They might only complain of chills or sometimes just a bit of confusion. What do you have to say there?
Yes. So definitely in elderly women, urinary tract infections occur similarly because one, there's less mobility. Two, there's a condition called atrophic vaginitis.
Okay.
Now that's a gynecologic condition. However, because of the hormonal changes, it becomes more prone to getting a bacterial infection. Additionally, because of the hormonal changes that happen after menopause, the opening of the urine passage, called the urethra, sometimes sort of closes in on itself. And so elderly women, they may pass urine, but sometimes they actually describe having to press on their bladder or press on their lower abdomen to get the urine out, or having to wait a long time for it to come out. And so all of these things actually require intervention in order to help them pass urine more efficiently. Because as I said, if you are not passing urine efficiently and there's backup anywhere in the system, that predisposes you to forming an infection. And in the elderly, they may not necessarily feel pain or burning, but once that infection is there and festering, it starts to affect their overall health and their overall body systems much sooner than in a younger patient who would have a stronger immune system.
And it's good that we put that out there, because there are a lot of people who are looking after the elderly people, and they might not think that a urinary infection could be happening in someone if they don't have burning or when they pass in urine. So this might be a little bit overlap between yourself and the gynecologist, but a lot of women complain of urinary incontinence as well. That, you know, sometimes they might have a little leaking, or sometimes they can't get to the washroom on time. Normally we think about the males, but sometimes the women can't get to the washroom on time before they pass urine. Urinary incontinence or urinary urgency. Can you just address that issue for the population out there?
Definitely. So to break it down, incontinence means leakage of urine. And there are different types of incontinence. There's something called overflow incontinence, meaning your bladder is so full.
And what age group is this normally?
Overflow incontinence typically occurs in a more elderly age group, where, especially if there's any nervous system problems, such as after a stroke,
Right.
And it happens because the bladder is full, but the bladder isn't getting the signals, or the patient is unable to actually pass urine.
Yeah.
Then there's something called stress incontinence, which commonly occurs in middle-aged to elderly women, and it has to do with increasing pressures within the body. So once you cough or sneeze, and there's an increase in your abdominal pressure, or if you lift something heavy, and it transmits to the bladder, and there's that weakness that just releases a little bit of urine.
Right.
That's called stress incontinence.
Right.
And then there's something called urge incontinence, which is where you have difficulty holding or postponing urination. For instance, you might be shopping in the mall, and you feel that you have to pass urine, but you must go now, and it's a race to get to the bathroom in order to safely pass urine in the privacy of the bathroom stall, and you have a little bit of leakage. That typically happens if you have an overactive bladder, and it means that you're having bladder spasms.
Right. Right. So that describes what that describes what is happening, right? What the complaint, and you've diagnosed the complaint. Is there treatment for it?
Definitely. So in patients with an overactive bladder, the treatment is both conservative measures as well as medical, primarily. So the conservative measures, what I try to teach patients to do is something called a Kegel's exercise, which is basically to tone the muscle of the pelvic floor in order to hold the urine to a more appropriate time to pass urine. You can also see a physiotherapist to do pelvic floor strengthening exercises, which will assist in the tone of the bladder in order to help maintain urine as well. There's also, for overactive bladder, there's a medication that we can use to sort of prevent bladder spasms. For the stress urinary incontinence, that's when you cough or sneeze, that would be when we would use the Kegel's exercises that I just mentioned, in fact. And depending on how much you respond to those measures, in some cases surgery may be necessary, but most people get good response or good relief with these conservative measures first. So that's something that would probably be tried first, depending on how each person responds in a different way.
Right. All right. So that's pretty interesting. I really discussed that the different ways to manage the urinary type symptoms in terms of incontinence in the women, and I suppose men also suffer from these symptoms, similar symptoms as well, but it might be more than likely related to prostatic disease than anything else, no?
Yes, definitely. In men who experience urinary incontinence, now they can have an overactive bladder as well.
But it's not as common, is it?
It's not as common. But predominantly they have some sort of either underlying prostate problem, or in some men who have received treatments for prostate cancer, sometimes they may have these issues as well.
All right, so Trudy, we're going to take a little second break now, and then we come back. So guys, we're here with Dr. Trudy Kawal, and we're discussing urological complaints. I'd just like to remind you that Trudy was here in January, and we did a whole program on prostate disease. So if you guys are interested, you could look it up on our YouTube, or you could go onto our Facebook page, and you could just go backwards, and you would see that interview there with Dr. Trudy Kawal on prostate disease. At this time as well, I'd just like to remind you that you could send in your questions to us, and Dr. Kawal will certainly answer it. All right, guys, we'll be back in one moment.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the mills polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. Trudy, so that's interesting about urinary incontinence and the urinary symptoms. I suppose the big field or the big complaint in Trinidad at the moment is kidney stones. It's painful. It seems like a lot of people have them. It disrupts their life. Tell us a little bit about kidney stones. What are the available treatments for kidney stones? I know you mentioned the laser, but how do you go about, what does the patient do when they get pain with kidney stones? They come into you, and how do you get them from being in a state of having pain with this thing in the urinary tract to being back to normal? What happens?
So
how do you move them back to normalcy and good health?
So first of all, patients with kidney stones, their main complaint is usually pain.
Yeah.
And pain is usually in the area of the flank or just in the lower back, towards on either side.
Yeah.
And pain, fever, vomiting, chills, all these things can indicate a stone with infection, or what we call obstruction, when the stone is causing a blockage to the passage of urine within the urinary tract.
Right.
Now, treatment of stones depends on many factors. So the first thing we need to do is actually diagnose, yes, there is a stone here. And to do that, we need to have some sort of imaging. And the gold standard of imaging is usually a CT scan of the renal tract. Now, sometimes you would see a stone on other types of imaging, like an X-ray or an ultrasound, but very often the CT scan is what will give us the most information. So once a stone is diagnosed, a kidney stone,
I think we have an image of it up there.
Yes, we have an image of it there. So those stones are located in the kidney, as well as in the ureter, which is the junction, the urine passage that the urine drains from the kidney.
Yeah.
So once a patient presents with these symptoms, whether it's pain, fever, chills, or any combination of those, they would eventually undergo a CT scan to diagnose if they do have a stone.
Right.
Now, treatment of the stone depends on many things. If the first thing is we have to see if it's an emergency, or if the patient just has a stone that's causing some pain.
Right.
If it's an emergency, what this means is that there's a blockage of passage of urine, which predisposes to infection, or actually affects the function of the kidney. So in tandem with the CT scan, we would have to do blood investigations to look at the markers for infection in the body, which is the white cell count, and also the kidney function. If the kidney function is elevated, the white blood cell is high, then this patient needs some sort of emergency intervention. Emergency intervention for an obstructing stone, meaning that there's a backup of urine in the system. And this occurs when the stone is usually anywhere along the ureter, meaning that the drainage of the kidney is impaired. So treatment is focused not so much on getting rid of the stone, because the stone harbors the bacteria. And if we try to break that stone up right then and there, what can happen is that the infection can actually spread further into the body. So treatment at this point involves just, first of all, antibiotics, but second of all, an intervention or a drainage procedure in order to release the backed up urine that is collecting behind the stone. So it's to allow resolution of the kidney impairment in the function of the kidney and allow any infected urine to drain.
Right.
And we need to get a hold of that infection. And so what we do is something called a stent.
Right.
So how I teach my medical students, a stent is like a straw.
Yeah.
It's hollow on the inside, but softer, smaller, and more flexible. And it's inserted endoscopically, meaning that there's no surgery, there's no open surgery, there's no cutting.
Yeah.
It is a surgical procedure, but it's done via cameras.
Right.
And what it does, it bypasses the point of obstruction, so it sort of snakes around the stone and allows whatever is backed up behind the stone to pass. And that stent remains in place for a few days, and you don't have to stay in the hospital with it. You can go home and come back once you are well. And electively, so after about a week or 2 weeks, then you'd have your definitive procedure.
Okay. So you have any slides with the stent? Or,
no, I don't have any slides.
So the stent goes in, goes behind the obstruction.
Yes.
Behind the stone.
Yes.
And therefore it sort of bypasses it, so you allow the passage of urine to come down away from the level of obstruction. It's like a bypass base. It's like a road on the side coming around.
Exactly. It's like if you take a smaller side road to circumvent traffic.
Okay. So that is, obviously that's not moving the obstruction. The obstruction is still there, the stone is still there. So that's why it's a temporary measure.
Yes.
And it's a temporary measure to give relief and to also allow the non-emergency and to probably give you time to treat the infection as well. Okay. What percentage of patients will end up with a stent like that when they're going to see the urologist with a kidney stone? Is it a huge amount, or is it a common procedure?
It is a very common procedure.
Okay. And so then the patient goes home, they come back in with a stent, and what happens next?
So next we have to figure out what is the best treatment.
Right.
In some stones, so if you need a stent, typically the stone is larger than 1 centimeter, or there's been some kind of obstruction.
Right.
So these are stones that won't really pass on their own.
Right.
So some intervention is warranted.
Right.
Now, there's non-invasive intervention that's called shockwave or extracorporeal shockwave lithotripsy.
Yeah.
And what that involves is putting, there's a special machine that we put against the body once we can see the stone on x-rays.
Yeah.
And this is amenable for small kidney stones and small stones towards the proximal ureter, which it means the beginning, the top end of the ureter.
Yeah.
And depending on the density of the stone and the size of the stone, which are all factors we can see on the CT scan, this machine fires basically ultrasonic waves, which is converted into energy, and it basically knocks the stone.
Right.
And so it knocks sort of cavitation bubbles, is what we call it, and this can result in fracturing of the stone, and the patient will eventually pass small stone fragments.
Right. Is the size of the patient relevant as well? Like if it's a heavy set man or?
Yes. So we have done it in bigger patients, but in general, internationally, the guideline is the stone to skin distance, which is measured on the CT, meaning the distance from the patient's abdominal wall or back towards the stone should be less than 10 centimeters.
Well, that's pretty small person, though. No?
No, so no, it's on the CT, not in real.
Oh, right. So if you have a bigger person, a heavy set man like myself, and the ultrasound might not be the most viable option for treating the stone, what would you do?
Right. So if
the patient is in pain,
if the stone is not amenable to shockwave lithotripsy, as I said, not all stones are amenable to it in the first place.
Right. Of course, yes.
The best treatment at that point would be laser lithotripsy, which has to be done under anesthetic. So it is a surgical procedure. Again, there's no cutting.
Right.
What we do is we go in with cameras through the urine passage.
Oh gosh, yes.
And we go with a camera, so we'll remove the stent.
Yeah.
And we go with a thin camera.
Yeah.
Up the ureter to image the stone.
Yeah.
And I think we have a slide of it showing the
Josh,
stone.
can you bring up that slide, please? I'm interested to see that.
And you'd see we then put the laser fiber and use laser energy.
Is that it there?
Yes, that is it. So the blue line.
So that's the ureter.
That is the ureter, which is the tube connecting the kidney to the bladder.
Right.
The blue line you see towards the bottom of the diagram labeled D would be the laser fiber.
Yeah.
And you see how it's basically in that one, the stone is already halfway gone, almost.
Right.
So if you look at the top pictures, you'll see the entire stone.
Right.
The green dot is the aiming beam of the laser fiber.
Right.
And so as we use that energy, the stone is pulverized.
Okay. And the patients get pain relief
well, the patient will be under anesthetic, but once they wake up, sometimes patients feel that soreness from just having the intervention. But in general, this can be controlled with analgesics, maybe a day or two, and after that, it's relatively speedy recoveries.
Why is the ureter used to gain access to a stone that might be right up, why is the urethra used to gain access to a stone that might be fairly close to the kidney or higher up? Can we go through the skin itself or the muscle or go into the kidney?
And we definitely do that again. So
I'm just thinking logically more than anything. I don't know if the technology exists.
Yes.
Okay.
Definitely. That's called a percutaneous nephrolithotomy, which we also do as well.
Oh, that makes sense.
That is reserved internationally. So the guidelines, that is reserved for stones that are 2 centimeters or more. In the mid pole of the kidney or upper pole, which is the middle and upper part of the kidney, or 1 centimeter or more in the lower part of the kidney. Now, the reason I didn't rush to say that first is, remember, even a small cut on the kidney is still a cut on the kidney.
Correct.
And so this is still a major operation.
I understand.
If we do it endoscopically, so if the stone is small enough to be amenable to using the ureteroscope, which is the camera that goes up, then this is no cut, no incision at all.
Okay, of course. I was just thinking logically, the logical progression from what you explained there.
Yes, definitely in larger stones in the kidney, we would have to make that small incision, and it's like about 1 centimeter, very small, and we dilate the tract and go in with like a keyhole, like a camera.
Exactly.
And then use the same energy sources to shatter the stone, but through a small skin incision on the kidney and going down to the kidney.
All right. So I mean, that's the treatment available for the kidney stone at the moment.
Yes.
And why do people get them? And why is it similar to urinary tract infections? Is it lack of hydration? And why do they get them? And how do we prevent them from getting them again? Because repeat stones, I think, is probably fairly common.
Yes.
And I suppose the success in urology would be to prevent people from getting repeat ones.
Definitely.
Because then you're going back to treat the same person again, using back the same. So if we could stop people from getting repeat stones, that would be a great advance in urology. Is there that movement towards finding how to treat people to prevent repeat stones? Is it a simple thing or is it a hard thing? Or what can people do?
Well,
you get my question?
I do, definitely. So it's definitely multifactorial, but I will say that worldwide, the most common reason for forming kidney stones is dehydration.
Right.
Especially in our country in the tropics.
Exactly.
I know we've been having a lot of rain recently, but typically it's very hot. So when I ask my patients who form stones what they do for a living, and every patient with kidney stones, I ask them what they do on a daily basis, followed by how much water do you actually drink per day. A lot of construction workers actually get kidney stones.
Because they're sweating and
it's because they're sweating. A lot of people say, Doc, I drink 2 liters of water every day. But they don't take into account they're outside working in the garden. They're doing work outside, they're busy, they're active. And so every time you sweat, your body loses fluids. So you need to drink enough water to actually make up for that, as well as keep hydrated. So if you think of if you've ever made a glass of salt water, and you fill the glass with water, and after you put a certain amount of salt, no more salt will dissolve because it's reached saturation. So it's the same concept. Your urine is essentially the water, the glass of water. If you don't drink enough to have enough, a bigger glass of water, when the kidney filters all the toxins and all the salts from your body, there won't be enough volume for it to dissolve. And so that's partly why it precipitates out as a stone. And once you have these little crystal deposits, more will deposit. And that is how a kidney stone builds.
Great.
Now, there are different types of kidney stones as well. There, in our population, usually calcium type stones are most common. So calcium oxalate, calcium phosphate.
Is there anything in our diet and in our population that might be contributing to increased stone formation? I mean, like, is it because people drinking lots of milk that you're going to get stones, or Is there any, like lots of cheese, we are real cheese population, does that contribute to kidney stones?
So from what I've seen with my patients, yes,
calcium supplements, we use calcium supplements in medicine. Does that contribute to it?
They may drink, yes, they drink milk and consume dairy.
Yeah.
But in general, most people consume dairy in moderation.
Right.
And so just how having a high calcium level can cause kidney stones, having too low calcium levels can cause kidney stones by another type of reaction in the body.
Okay.
So the international recommendation is actually to have a normal calcium intake.
Right, okay.
Now, as I said, most commonly it's dehydration.
Okay, that's
most kidney stone patients, they admit to not drinking a lot of water during the day.
Right.
And once we get that under control, usually it's fine.
All right, so I just want to interrupt you there. The big question, other than water, a man has a kidney stone, he gets rid of the kidney stone. Bear in mind we have about 2 minutes left in the program. Other than the water, is there any other way to prevent him from getting a repeat kidney stone? Or is it the water alone or the lack of water that will contribute to the secondary stone?
No. So as I was saying, there are other, in your body there's stone promoting and stone inhibiting factors, and you have different types of stones. So in some people who have high uric acid levels, such as people with gout, they may actually form uric acid stones.
Right.
And so one of the things, the diet that we talked about before, the DASH diet, and that is a low salt diet that is recommended for the prevention of kidney stones.
Right. So what I'm getting back from here is that you might do a surgical treatment for the patient who has the kidney stone, but what you're really saying is that the doctors, the physicians, the GPs have to look at the overall health of the patient, analyze those things like his kidneys, his uric acid, stuff like that, and treat those conditions, and that will minimize the recurrence of a kidney stone.
Yes.
So Trudy, we've come to the end of the show, all right? The hour has flown by again. I'd just like to thank you for coming back on the program.
Thank you for having me.
You're very welcome. What I really liked about the program today is that we had a discussion, but we went through the logical sequence of events of why certain things happen in the body in your field, and why we give certain treatments, and you really explained the logic behind it, and I thought that was really nice. Thanks a lot. So guys, we'd like to thank Dr. Kawal again, and we'd just like to thank you for tuning into the program this week, and we will see you again next week. I'd just like to thank Josh for helping us produce this program tonight as well. All right, guys, so take care of yourself. We'll see you again next week. All the best. Have a pleasant evening. Take care of yourself, everyone. God bless.